But so I just want to, first of all, tell you this is a wonderful book. And I've known Mike for quite a few years. He's a man of intelligence, insight, compassion, and integrity. And not everybody who's served in Rhode Island government can you say that about. So, he had a great tenure as the state's health commissioner. In fact, I wish the legislature had listened to him a little more when he was there, but you know what Smith Hill's like. It does provide a lot of grist for our mills as political reporters. And not only, hopefully tonight, will we get to the diagnosis that Dr. Fine has, because I think it's profound, but unlike a lot of these kind of healthcare policy people, maybe sometimes we refer to them as bloviators, he not only has a diagnosis, he actually has some ideas for cures, which is one of the things I think that we all ponder these days as we look around at this huge healthcare system we have, and we just wonder, where can we start? One of the things that I was really surprised to learn was that the projections show that by 2025, that 50% of household income could be spent on health care and health insurance. And even now, we're spending $10,000 for every American. And we don't have the world's best outcomes. We have the most expensive system, and our outcomes are not as good as other countries. So I just want to get here with Mike. When you say, Dr. Fine, that we have a healthcare system, we really don't have a healthcare system. What we have is a healthcare services market. What do you mean by that?
Well, if you look around the world at what other places do, other places organize their healthcare in a intentional and systemic way. That is, they figure out what services everyone needs, and they provide those services to everyone. We figure out what we're going to pay for everyone, and then see who happens to get those services. And if the right people get those services, we're lucky, but just lucky. You know, our approach to health policy is something like begging. We just put out money and hope that we're going to get the outcomes that we need. I was very much entertained isn't the right word, but I was kind of interested in one of these talks about a year and a half ago. I talked to a woman who lived in Barrington and was originally an Italian citizen, and then went back to live in Italy for a year and a half. And when she got there, one of the things that she did was she had to register her passport with the local police. So she did that and was astounded that 2 weeks later she got a letter in the mail saying that her colonoscopy was overdue. There was somebody in Italy, and I'm not sure I understand all the process of the Italian healthcare system, but there was somebody in Italy making sure that everybody over 50 had a colonoscopy, which sounds small, except it's really important if we're going to make sure that we get the best outcomes. Because for a disease like colon cancer, colon cancer is an entirely preventable disease. Yet we have 50,000 deaths a year in the United States from colon cancer, all of which are preventable, because we don't have a way to make sure that every American over 50 gets a colonoscopy every 10 years. It's no more complicated than that.
You know, there's part of what you say here is we spend money on the wrong stuff. And I'll quote, in many respects, the culture of consumer capitalism is our major public health challenge. Try saying that on the 6 o'clock news. And one thing that you point out here is that democracy and health are kind of inextricably linked. And we don't consider health a public service like we do, let's say, the Situate Reservoir, the water that we drink, or the police and fire services that we also depend on.
And yet, if you look at international comparisons and look at all sorts of health policy data, it becomes really clear really quickly that at least primary care is an essential service, very much like education or public roads. It is something that every single person needs. There's nothing in the primary care enterprise that has anything to do with insurance. We know what everybody's primary care costs. We can predict it with precision. It actually turns out to be incredibly inexpensive. And we could very easily give it away to all Americans. And if we did, and did it in a way that all Americans had it and had it close to home, there are very good projections that suggest we would drop the cost of healthcare in the United States by 30 to 50% and do things like massively increase our public health outcomes. When you look at other countries in the world that organize themselves this way, we would expect an additional 3 to 5 years of life expectancy. We'd expect to see our infant mortality drop to a third of what it is now. There are many things that other countries do and do well simply by providing primary care to every single person.
It's kind of fascinating to me that you say that democracy are inextricably linked, but are failing. Now, this isn't for a lack of government agencies involved in healthcare. I mean, when you read this book, he really does a good job of portraying this dizzying array, this alphabet soup of government agencies that have their fingers somewhere in healthcare. CMS, the CDC, Medicaid, Medicare, all of the various state healthcare advisory councils and groups, insurance commissioners. I mean, the list goes on and on and on. And yet, we still don't seem to have any control over either the cost or the delivery system of healthcare. Now, that intrigues me. Why is that?
I think it's just a historical accident. When you look at how we put things together, we created our insurance system in the 40s, toward the end of or right after the end of the Second World War, when there were price controls, and the only thing that employers could give their employees, because they couldn't give them wage increases, they could give them benefits, and so they gave them insurance, and that process got separated from any organization in terms of the delivery system. At the same time, we thought of medicine as a for-profit business, run by small entrepreneurs. So in those days, every doctor was, sort of a little economic enterprise of her or his own, mostly his in those days. And some of them began to open, in order to improve their profit margins, they would open a wing of their house and let people stay overnight. And those are where many of our hospitals came from. But nobody sat down and said, what services does everyone need, and how do we provide those services to everyone? That just wasn't part of our national ethos.
Yeah, I'm thinking back, though, on some of those early initiatives when the United Auto Workers, one of the vanguard unions in this, negotiated the contracts to give their people health care. Everyone thought that was a huge breakthrough.
And it was, because lots of people didn't have access, particularly to insurance, and many people couldn't afford the hospital part of insurance in particular. In those days, primary care physicians were part of their communities and would often see people for free. The Dr. Kildare, it wasn't Dr. Kildare, the other guy.
Dr. Welby?
Dr. Welby was kind of the sort of archetype, and that worked for everyone, but it was affordable. I'm old enough to remember when health insurance first started covering primary care. It didn't always. It started with hospital care.
So it was really catastrophic insurance more than the model that we have today.
Exactly. And if you think about it, there's nothing about these routine services that have anything to do with catastrophic need. They are essential needs, and we just lump them all together as health insurance companies tried to get control of the market.
And Walter Reuther, of course, and the UAW, the idea there was really to get some kind of universal care. And of course, Truman is the first president to actually advocate, Harry Truman, way back when, for what we now call universal health care.
As he did, my colleagues in the American Medical Association resisted that kind of approach.
Socialized medicine, right?
That's what they said.
The red flag.
Right? And they were afraid that someone was going to take their business away. So the compromise we came up with was, gee whiz, it's okay to have health insurance because all physicians and hospitals got paid a little better, mostly because all of the people they took care of suddenly had a method of payment. So it was okay for everybody to have insurance, but it wasn't okay for government to think about how to organize the distribution of services. And that was, in part, I suspect, my colleagues at the AMA fighting any attempt to do that tooth and nail. There is, I have some colleagues who are part or work in community health centers in this room tonight. And we ought to talk about the community health center movement for a moment at some point. But one
will.
Go ahead.
No, we will at some point, but I want to lead up to first.
But one little interesting piece of history is as community health centers themselves were getting formed, the AMA went to battle. And in the early 20 or 25 years of community health centers' existence, they were essentially not permitted to take private health insurance. They existed only to care for the underserved and were only there to take care of people with Medicaid or people without insurance. And like I said, we'll talk about community health centers in a moment, I suspect.
Yeah, you point out that you say in the book, this is a great one, I'm no communist. Markets are a great way to sell tomatoes, cars, and television sets. And I don't think we argue with that much. But the market just doesn't work for healthcare. And you do say, you acknowledge that sometimes some people get the medical care they need, but that's more by accident than design. What do you mean by that, Doctor?
Well, there is no one who's responsible for sitting down and thinking out who needs what.
So there's no accountability, you're saying?
There's no accountability. Today, in Rhode Island, 45 to 55% of Rhode Islanders don't have or get routine primary care. And, the primary care piece isn't the end of the world, but what it does is it provides an opportunity for people to get the prevention they need, the colonoscopies and the flu shots, and checking in on their weight and blood pressure. And those are the things that turn out to matter most for health. And we have no system to make sure everybody's got all of that stuff because we don't have a system of care in which some provider is responsible for every single person.
It's interesting how you kind of trace this from Marcus Welby and these very small interactions with doctors locally to this mega healthcare system that we have today, in which about a third of the money is going to hospitals.
Mega market. About a third, actually closer to 40% goes to hospitals. And just one little observation about hospitals, and this is something not everybody knows, that about 65% of hospital income is public money, Medicare or Medicaid. And yet all those hospitals, or almost all the hospitals in the United States, certainly the private nonprofits, who are the bulk of the hospitals in the United States, they are private boards with no accountability whatsoever to anyone. And we have this unusual situation in which private nonprofits running with public money are competing with each other to sell services.
Protected by the government from paying taxes, by the way.
And yet paying their executives more money than I want to think about. And yet...
I was wondering, why is it that the president of Brown even, or the University of Rhode Island, or other very, very important nonprofit institutions in our society make so much less than hospital executives. How did that get to be?
I'm not sure I know the answer to that.
I mean, it's like a 10 to 1. Somehow Dr. Dooley down at URI can exist and feed his family on about $350,000 a year, whereas if you look at the lifespan CEO, we're up around 2.8 million, I believe, or 3 million.
I have stopped counting.
Yeah, I'm not good at math. I can't count that.
Yeah. But, you know, I mean, they have compensation committees, but, you know, they have their own internal process, but most of those internal processes really have to do with CEOs working with boards that are self-appointed. Nobody on a hospital board is elected by anyone. No one on a hospital board is accountable to anyone. Actually, one of the things that I liked doing most when I was at the Department of Health was bringing members of the hospital board together to the Department of Health and trying to lay out what I thought their responsibility was. They almost killed me.
I can only imagine.
But I thought it was worth the attempt.
It certainly is nowadays, because we look around and even when we expand care, like Obamacare, it's still well nigh impossible to get any kind of a grasp on the costs. And I'm just wondering, what are your insights on that?
Well, actually, the explosion of cost was predictable. And I was working with some people in 2009 that actually was able to predict with pretty good precision what that explosion of cost was going to be. And it's because we have an insurance process instead of a healthcare system. You know, we know the cost of services, and when we go deliver the services directly, those costs are capped. But when we essentially give people a credit card for which they have no responsibility whatsoever, which is what we do when we give them an insurance card, everybody you know, rushes to spend as much money as possible. When we let pharmaceutical companies bill insurance companies for medications that used to be expensive, all of a sudden there's nobody minding the store and the price goes through the roof. I don't know if you've heard about the cost of insulin now, but the cost of insulin, which used to be, you know, a couple dollars a vial, and which even the most sophisticated insulins actually cost $3 to $5 a vial to manufacture. That's now costing $300 to $500 a vial if you have to buy it for yourself, and that's just the co-pays. The actual cost is probably higher. So we've now heard of a number of particularly young people who, after they got to 26 and ended up off their parents' insurance, couldn't afford the insulin, started trying to stretch it, and ended up dead. And that is not infrequent. I've just heard a story from a friend I just mentioned to you, actually, in New Bedford, who has heard about a number of his patients who are flying to Portugal a couple of times a year to buy insulin there because it's cheaper for them to get on an airplane than it is to buy their insulin. You know, how did that happen? And you know, those of us who practice have seen tried and true medicines get manipulated and disappear from the market and reappear, costing 10, 20, 30, 40 times what they used to cost. EpiPens, which used to be $20 or $30 or $35, are now costing $400. And that's just market manipulation and nothing else, and with no value received by anybody.
I mean, one of the most outrageous things that Obamacare perpetuated, didn't change really, but perpetuated, to get the deal through with all the lobbying, they had to allow this loophole, the pharmaceutical companies saying that government-backed health care, such as Medicaid and Medicare, except for the VA, I believe, are not allowed, the Veterans Administration, are not allowed to negotiate any price discounts. Now, I know when you were health commissioner with vaccines, you were able to put together some modest programs that really did help the state.
Well, you know, to the truth is, I had nothing to do with putting them together. I got to administer them. They existed for 20 years, and they continue to exist. The Rhode Island Universal Vaccine Purchase Program, which is one of these little things that almost nobody knows about.
Right.
In that, we basically lift a certain number of money per person per year from every health insurance contract. Everybody who has health insurance, we take a couple $100 from your health insurer, bring it to the Department of Health, and group purchase. We buy all the vaccines that everybody needs in the state of Rhode Island. We buy them as a state. That saves us 15% off the top because of the group purchase. We supply it to everybody who does a vaccination without charge, and we have become the best vaccinated state in the country. To me, that's an argument against using the market as we use it.
Right. I'm wondering, when you say a third to perhaps a half of every dollar that we spend on healthcare in this country is wasted, what are the major issues here?
Well, there are bunches of them. One is what's called overuse. The use of technologies that people didn't really need, mostly because somebody was anxious to sell them. So those are surgeries that people didn't really need. Or, for people with back pain, there's something called the injection of intrathecal steroids, which means usually an anesthesiologist brings you in and puts a needle into the space between the membrane covering the spinal cord and the spinal cord itself, and injects some steroid, usually at a cost of thousands of dollars. My colleagues who do those can do 20 or 30 a day, and there's no evidence whatsoever to suggest that intrathecal steroids is any better than physical therapy. And to make things worse, in 2013 or 14, I don't remember the exact year, we had an outbreak of meningitis, of a fungal meningitis, that came from the injection of a incorrectly prepared steroid out of an organization in Massachusetts. It caused a couple of hundred deaths and untold craziness. And that was all because of the overuse of a process with no evidence supports.
Is there something psychological about Americans where instead of the least invasive thing, we are conditioned to think that, you got to find the best surgeon. You've got to go out and get that back surgery. It's like every time you see a ball game, finally Tom Brady got sick of this. It was interesting to me to see Tom Brady's career, where he adopted more Eastern medicine and stretching and many more techniques like that, because he saw and got sick of the idea that what they do in pro sports is simply keep cutting and cutting and cutting. And again, putting more cortisone into your back or your knee or whatever you have. So I'm just wondering about that.
Well, I actually don't think this is just something about Americans. This is something about the marketing process. One of the things to remember, we've got a $3.3 trillion industry, in which the last time I sat down and did the math, there was about $100 billion of marketing that went into various parts of the system. And that $100 billion of marketing is pretty persuasive. And I think that's what really lies behind all this. Then we have some sort of structural entrainment where, because we don't have a healthcare system, people go to what's ever open, which basically means people who don't need to be there often go to the emergency department. The emergency department works with orthopedists and neurosurgeons, and so, and other specialists who are trained to do things and make their livings from doing things. So we have been doing things. And that's stoked by... So
we have a bias towards more procedures, is what you're saying?
We have a huge bias toward more procedures. We've got device manufacturers who are encouraging my specialist colleagues to do more procedures, sometimes You'll find the representatives of those manufacturers in operating rooms helping people choose which is the right artificial knee to put in, but there's a whole bunch of incentives that happen to people to get them to do more, not do less, and that's where we are, how we got to where we are.
Now, one of the things you do say in the cure, it sounds reasonable. If you read the book, you'll find that why don't we have community health centers, places where people can go, they'll be open from 8 in the morning, say to 8 in the evening, so that if your kid falls on the tricycle and gets scraped up and needs a couple stitches, you don't have to go to this high-tech emergency room. How come we can't set up a system like that? I know you're trying, and I want to talk to you about some of the exciting things that you're doing in Central Falls. But how come we could never forge this kind of system?
I don't know the answer to, how come we didn't. Clearly we didn't. But at the same time, we saw the community health center movement develop. And we actually have more of it than most people understand. I think we turned over the development of our health services to the private market, and the private market did what it wanted to do and didn't think about, the private market did what we asked the private market to do, which is to make profit. They did a really good job of it, but nobody asked the private market or anyone else to improve health outcomes for all Americans.
I was taken by something that always baffled me. When you go to a hospital or even a doctor's office back in the day, you had all these people wheeling paper files around when the rest of the world was all going digital and getting into the records. I mean, your bank didn't treat you this way. Your university didn't treat you this way. It's almost like nowhere in society except for a hospital where we still a big file cabinet. And yet everybody said electronic records were going to be a panacea in healthcare, but it hasn't really turned out that way, has it?
Not even close. We spent $19 billion in 2009 as part of the High-Tech Act of 2009. And you would have thought we would have created a single electronic medical record system that everyone could use. In the VA, there's a electronic medical record system that has been used for a number of years that many people think is quite good. It's called Vista, and it was available to everyone for free. But instead, because of the process of the market, instead of having a single system that everyone could use and could use to support patient care, we got many different sellers of electronic medical records competing with each other, mostly to sell records that were there to help the billing process instead of helping the care process. And so, every clinician I know curses their electronic medical record and the work they have to do for it. And almost every clinician I know works hard all day long and then goes home, and between 7:30 or 8 at night and midnight is up putting in, sort of dealing with the records and making the recording and the chart that they needed to make, because they want to spend their time looking at and to patients. And these records don't even talk to each other. So what we have is a huge mess. A $19 billion, at least a $19 billion mess, and no coherence. Whereas, I had the opportunity when I was at the Department of Health to meet some folks from Northern Ireland who were coming through and were trying to learn about what we did, and they mentioned how they were about to put an electronic medical record system in for Northern Ireland. They spent $17 million and got electronic medical records for everyone, and those records talk to each other. And when I talk to colleagues from around the world, they all love their electronic medical record systems. We're the ones who hate ours, and they can't understand why we hate ours so much.
We allegedly have the world's best technology. What you seem to be saying is that hospital CFOs are designing the system more than medical practitioners.
I'm not sure who's designing the system. I actually think it's IT people at the end of the day, but they're designing them for the CFOs in order to make sure that the billing process works, because we've got this backlog. We keep trying to figure out how to pay for it and pouring money into it without ever being clear about what the it is. And the it is actually pretty simple. It looks like community health centers, and it's one primary care thing for every 10,000 people. As you said, open from 8 o'clock in the morning to open to 8 at night and open on weekends. So that if you're sick today, you can be seen down the street, and you don't have to use the emergency department unless, God forbid, you actually have an emergency. It turns out that 50% of people who use the emergency room could have been taken care of in a community health center or in a primary care practice. And even more who use EMS do that, and that's because there just aren't any other options for when you're sick that day.
One thing that astounds me is how the system doesn't, either on a cost basis or on a treatment basis, do well dealing with folks with chronic diseases. Now, I know you mentioned diabetes, which to me seems like about as good an example as anything.
Well, you know, diabetes is a challenge in lots of ways. In one, we probably have manufactured most of the diabetes that we've got by subsidizing the overproduction of corn and wheat, and by, you know, fairly challenged diets, as people eat way more than they need, and they eat way more than they need in part because that's what the marketing process convinces them to do. And then having teams of people, you know, helping people in communities start to exercise and, you know, learn about how to make and eat a healthy diet. You know, we don't have that much organization or coherence community by community. And I think that's part of why we have so much trouble, you know, with diabetes being the cause of lots of our healthcare spending by itself.
Yeah, one of the things I'm intrigued by this book is when you talk about the need for political involvement, because you look at some things that are really beyond the orbit, you would think, of medicine. But then when you think about them, they're really not. I mean, just this last couple of weeks, we've had the NRA going ballistic on doctors who mentioned that, you know, we're spending an awful lot of money. The CDC's not allowed to study guns. A good example I think you bring out in the book is food stamps. Why can't we require a program that's supposed to help farmers? Actually, the people who really did food stamps back in the 1970s, and you don't really touch on this, but I studied it myself, were two people who didn't agree on an awful lot. There were Bob Dole and George Mcgovern. Now what they had in common was they both represented states, corn and wheat, where they had agricultural surpluses. And Mcgovern came from the Food for Peace movement, probably, and Dole wanted his farmers to have a bigger market. And the idea was to sell bread, milk, the kinds of items that were both nutritious and would help the folks who needed it, who were too poor to afford food. We had the WIC program, Women, Infants, and Children, and you merge that with giving farmers bigger markets. And yet we never really got there with healthy, a way to help the small farmers and get healthy outcomes with food.
Often because of the marketing power of big agribusiness, who, you know, folks who want to make what I sometimes call food like goop, you know, you know, the folks who make things that come in wrapped in cellophane packages that are, you know, calorie rich, salt rich, and incredibly bad for you. They want their market share, and they have lobbyists, and the lobbyists shut down any attempt to change that conversation.
Well, that's certainly something. The other thing you do here, and you point out very, very, well, brutally in some respects, is how the costs are built in. Now, it strikes me that when you talk about $3 billion, an awful lot of that money is salaries.
3
trillion, excuse me, I got that wrong. No, I'm sorry. 3 trillion. And a lot of that money is salaries. I mean, one thing that the healthcare system is in this country is a fairly large jobs program. They're decent jobs. A lot of them are unionized at hospitals, unlike business today. Nurses, there are a lot of professional people who are well-trained, who make decent salaries. You know, you have everything from, you know, nurses, the folks who are support staff, the drug reps who all look like SEC cheerleaders. You can always tell, my wife who's a doctor always tells you when you go to the hospital, you can tell who the drug reps are because they're all dressed up looking like they're headed out to a party, not to work. And I'm just wondering, it's almost like a huge jobs program, isn't it?
Well, think about this. If you look at the healthcare dollar, about 20% is spent on insurance company marketing, overhead, and administration. So we're actually up to about $11,000 per person per year. So 20% of that is about $2,200 per person per year. They get 20%. The primary care people, the family doctors and internists and pediatricians, you know, who are supposed to be available to their patients 24 hours a day, at least by phone at night, you know, who fill out their forms, who renew their prescriptions, who are there for them when they're sick, et cetera, et cetera. Anybody who doesn't already know, want to guess how much we spend on the primary care piece? We're spending 20% on the insurance companies. 10%? Remember, 10% would be $1,000 a year to keep their doors open, to be available 24 hours a day, to see people when they're sick and so forth. So you think $1,000 is enough?
Per person.
I'm sorry? Anybody else want to guess? It's actually 5% or $5,000.
Didn't want to give it away.
$500 per person per year. So, you know, think of that situation. Here we have the process that actually turns out to be the effective part of the actual healthcare system, the primary care piece. And that's living on 5% of our spend, but we're spending 20% on a business process.
The remarkable thing about your perspective is that you actually, you know, had the big title. State Health Czar, as we used to like to call people, you know, journalistic shorthand. And yet, you know, you point out that change, this is like Sisyphus and the rock. If the only way you get change sometimes, when you think about this deeply, is, well, maybe there'll be a really awful malpractice case. And that there'll have to be some change come from that. But what is this kind of clotted bureaucracy that we deal with?
Well, I think that bureaucracy is itself, you know, sort of internally facing and self-reinforcing. And so the only option that I can think of is a community-by-community organizing process to open the political space to change it. You know, we're up against, as I said, a $3.3 trillion industry. They spend about 0.03% of their profit on lobbying. That's $500 million a year. These numbers are so large that, you know, it's going to take a movement like the abolitionist movement or the civil rights movement or the movement for marriage equality. This is going to take something that has to sit in every community and move community by community if it's going to succeed.
Well, you know, your diagnosis is so, as Scottish people would say, dour or door, as they say in Scotland. But there is, now that George Bush has passed, there is a small piece of light here that you're actually doing. Since you became health commissioner, you decided to go back and actually try to put together a model system in Rhode Island's poorest community, Central Falls. How does that work? How did you get the inspiration to do it? How did you get the money for the new facility that you're going to open pretty soon up there?
So the inspiration actually came from the people of Central Falls. We were required at the Department of Health to begin a process of what was called public health accreditation. In order to do that, we were supposed to do something called community health assessments. Now, there was the easy way to do a community health assessment, which was to compile a bunch of statistics and put them in a notebook and send the statistics to the accrediting agency. But we thought we would do it a different way. And so we decided to have meetings in every community and listen to what people thought and what people wanted. Actually had lunch where we had that meeting now 5 years ago. It's in a restaurant called La Casona, which is on Broad Street, and it's actually quite good. We got 100 people to come. It's a Colombian restaurant. We did the meeting in Spanish with English translation, and we set up tables of 8, had people talk to each other, and then report out. And what we heard was pretty clear. What people wanted was, they wanted better access to primary care. They wanted more places to exercise, because the city had just been through bankruptcy and it had lost its community center. And they wanted to make sure their kids were safe at school in the days after it was right after Sandy Hook. And so they were afraid for their kids. And that really became the inspiration. We put our heads together and said, how can we get this done? What we came up with was something called a neighborhood health station. There is now one operating in Situate, where I live, and there's one that is operating and we're finishing the building, but it's been operating for 3 years in Central Falls. This will be a single place. It's actually kind of a community hospital without walls. 47,000 square feet, 14 doctors, 4 dentists, a bunch of mental and behavioral health people.
Well, let's get granular, Doc. How does that actually work? How do you set this up? How do you control the patient stream, and how do you treat people?
I don't think there's a way to control the patient stream other than to make sure we have enough people to take care of the entire population of Central Falls. And so we have those people, or we're recruiting.
But they're not just doctors, right?
They're doctors, they're nurse practitioners, they're physician assistants, they're dentists, they're oral hygienists, they're medical assistants, they're social workers, they're recovery coaches. This big team of people. They're EMTs. So I was working today on developing a process that will let EMS move people to this neighborhood health station instead of the emergency department. When there's somebody who calls 911 for a cough or a cold or a headache, where they don't obviously need the emergency department. So it's this team of people. We get the team together once a week on Friday afternoons, and we just work together figuring out what everybody needs and how to get that done together and get it done effectively. But that only becomes meaningful when you have enough critical mass in place and you have most of the people taken care of in the same place.
Isn't it difficult, though? We look at some of the contradictions here. Pawtucket, an underserved community, just lost its hospital, essentially, Memorial, and yet here in Central Falls, you're able to put together a system that's flourishing and will even be larger, hopefully, with your new facility opening very, very soon. How does that happen?
I think it's political will. Central Falls went through bankruptcy. It threw off some of the old politicos. It ended up with a young, full of energy city council and a young, full of energy mayor who wanted to do it differently. And so that's the democratic process, where people said, enough of this, we're going to do it better for ourselves. And they rolled up their sleeves, and sure enough, we're doing it. We've got a school-based health center. Central Falls used to have the highest adolescent pregnancy rate in the country. We brought that down considerably with the school-based health center. We're going to be open from 8 o'clock in the morning to 8 at night. And we're also going to be about building jobs, because when this thing is up and running, we'll have 100 to 150 people working there. There are people from Central Falls, by and large, and that becomes an economic engine for the city as well. And the opportunity is not just to do it in Central Falls, but to do it in every community of 10 to 20,000 people.
To me, the Central Falls experiment, or the pilot program, has been a fascinating one, and talking to the doctor over the years about it. Now, what does it take to replicate that in some other communities in Rhode Island? Because it's not as if Central Falls is the only underserved community on healthcare.
Well, I would argue that this is a good model not just for underserved communities, but for all communities. And what it takes is a bunch of angelic troublemakers. That is
Good line, angelic troublemakers. Don't we like that one?
That is to say, people who get together in their living rooms or in their kitchens or even in a bar and get together once in a while, once every month or so, and figure out how they're going to do this in their own community. We have, we have put together a little organization at the George Wiley Center. The little organization is called Healthcare Revolt, that tries to get people to replicate this in their own community. And actually, there's a sign-up sheet. My friend Ellen Borzimmer, I think, has it. So if you're interested in learning more about it, please give us your email address. But this is going to work when the democratic process works. That is, this is going to work when people start making it happen in their own communities. People can do fairly straightforward things like moving their own health care to community health centers. Community health centers are particularly amazing and unusual because 51% of community health center boards have to be people who are served by the community health center. So it is possible to get effectively control of the community health center and start to tip it more toward taking care of everybody in the community. There are a whole bunch of things people do.
But there's a professional community here too. There are caregivers. Now, in your book, you actually advocate for the unionization of doctors, and I can understand that. I had an intern in the other day who asked me, what am I going to do when I retire? I said, it'll be pretty soon. This kid actually went to Brown. I said, well, I'm going to collect my pension, Social Security. Oh, Social Security won't be there for me. How'd you get a pension? I said, well, I had a union job for 25 years. The kid said, what's a union? He said, well, if your generation doesn't figure out pretty soon what a union is, you could all be in pretty big trouble. I'm just wondering, what can caregivers do, people in the business? I know you are a good example, but there's a lot of millions of other folks out there who put food on their family's table by working in hospitals, clinics, insurance companies.
Well, I think clinicians and healthcare workers can do a couple of things. One is, certainly physicians, nurse practitioners, and PAs now almost all work for somebody else. Even 20 years ago, we were, I think my guess is 75 or 80% self-employed. Now we're 85 and 90% employed by others. That by itself says it's time to do some thinking about organizing. I'm a great believer that when clinicians organize, they should organize themselves and direct attention to advocating together for patient care, which is what's actually worked well in Great Britain. I also think clinicians need to come together and help join these local organizations, and I actually think we need to tithe. I actually think we need to take some of the, what I think of painfully as ill-gotten gains that we've all gotten, for better, for worse, we all get paid pretty well, and put a couple $100 a year into a pot and use that pot to do some of this organizing work to support the development of these community-based organizations that can, and I think will, end up developing these neighborhood health stations or community health centers, whatever you want to call them.
Back to Rhode Island for a minute. You were the top honcho in healthcare. You dealt with the legislature. What are the biggest roadblocks to change here in Rhode Island, the stuff that we can control?
I think the biggest roadblocks to change is a kind of conventionality about we've always done it this way.
Right.
And that's where you need people in many different communities stirring up their own trouble. You know this better than anybody. This is about the process of opening political space. Politicians and the legislature will do what they have to do, and they won't do anything else. And that means that it's the job of the rest of us to make them have to do it. And I really believe that when we have, in Olneyville and in Edgewood and in Cranston and in Warwick, in Connecticut, these little organizations, then they will convert the legislature. That's what the legislature will do.
One thing I've always noticed at the State House is that when it comes to medicine, that all the lawmakers, and I understand this, look, they have to answer to their constituents, that they never think about the entire state as a whole when they think about delivering health care, but they all are very tenacious about protecting whatever they have. Therefore, Woonsocket, with Landmark, years ago, they actually allowed them to go into this very high-tech heart training, where they were doing heart surgery, catheterization, I'm not a great pronunciation there.
Catheterization.
Yes, thank you, doctor. And, the thing was an abject failure. They raised like $600,000 or $700,000. They lost a ton of money. And the same thing when you look to close one of these old Hillburton hospitals built back in the 50s, the community rises up with a huge outcry, and people are upset, and you can see why. Part of it's the jobs, part of it's psyche, I think. The communities have a certain psychological attachment to having a hospital, and you can't blame people for that, but you look at some places like Newport Hospital, without the huge endowment that Newport Hospital has, there is no economic reason for that to be open, seriously. And you probably know this and there's other hospitals like this too.
We projected when I was at the Department of Health that we have twice the number of hospitals that we need. And the only reason they stay open is for political reasons. But that will change when we all start to get together, community by community and neighborhood by neighborhood, and start opening our own neighborhood health stations so that people feel like they have a meaningful alternative. I think we're kind of running out of time.
Well, I'm going to ask you then to wrap it up, and I want you to finish with a flourish here, doctor, and give us, you guys a great diagnosis. I want to know, let's give us a little more about the cure.
The cure is democracy itself. That is to say, the cure is people in communities organizing themselves to take over their own health care and build small healthcare systems, one in each neighborhood, one in each community, and then work together to bring them together and make a healthcare system from the ground up, and use that to collapse the behemoth of the market that's draining us all dry.
Thanks an awful lot. The book is Healthcare Revolt by, again, Dr. Michael Fine, How to Organize, Build a Healthcare System, and Resuscitate Democracy all at the same time. Now, that's a big prescription. But it's a fabulous book, and thank you all for coming. It's available if you want to buy it right up front.
Thanks to Tom and Emma, and Riffraff, and CGMA, Scott McKay.
You're being awfully generous, but thank you.
Thanks again. If you have some time to hang out, if anyone has questions, sure. Anyone?
I don't think I need the microphone.
Everyone.
So I'm fascinated by your suggestion of community by community. The best healthcare system that I have personal involvement with is in Israel, which is just the opposite in a way. It's a national program. Now I know it's a nation of 8 million people and not 300 million people, but still in all, it works. It works extraordinarily well. Doctors make house calls. You have a choice of signing up with one of 4 essentially insurance companies that then organize both geographically and nationally to provide whatever services you need. And you might have to wait 2 weeks if you need to see some dental specialist. But if you need a person to come because you can't move your leg and you're at home, within an hour, a doctor shows up.
So the Israeli system has devoted a fair amount of time and attention to the primary care piece. Though there are 4 large, what in Israel are called HMOs, they are much broader than that.
Yes.
One of them is dominant by far, and it provides primary care in every neighborhood, and even on every kibbutz. They have really developed the ability to do this, and the number of primary care people is many times what our number is. They spend, as a percentage of their total spend, 3 times what we spend on primary care. Because they understood somehow in their bones, like every other healthcare system internationally that matters, they understood you gotta provide primary care to everybody, and that's the place to start. You see that in Great Britain, you see that in Finland, you see that in Cuba. The Israelis and the Cubans are particularly good at drilling it down to the neighborhood level. Even more granular than that, they go to the block level. In both in Israel and in Cuba, they often have either a nurse or a doctor on every block, and those people are responsible for everyone in that geographic area. They take that responsibility seriously, and they take their care into those neighborhoods and into those blocks in ways we can only dream of.
So why is the solution for us, as you describe it, very grounds up, whereas their solutions, and I don't know how old the Cuban one is, but I assume it's from 1960, Cuban Revolution time, and the one in Israel we know is from 1948, for give or take, and they managed to do it top down in a way that was a national model that has evolved over time as healthcare needs have evolved, but still is a top-down, we're going to do it this way kind of model.
I think they came out with top-down pieces, but they had a structural process that was much more granular originally. The Israeli experience, which I know a little bit, actually came out of the Israeli labor union. So that they have 4 large national organizations now doesn't quite picture the history of the granularity from which they came. And the reason I think we have to do it from the bottom up at this point is there's a $3.3 trillion behemoth sort of clamped onto us that will suffocate us if we don't do something differently. There's no way to take it on frontally without huge amounts of resources, but if we build it from the ground up, I think we can sort of collapse it quietly by changing the dimension. And here's how that works quite specifically. It actually references something I said before. If we actually did the numbers, and if we did this in Rhode Island, it turns out to be not terribly expensive, but if we did it in Rhode Island, we would drop the number of hospitals in half. And if you drop the number of hospitals, you radically diminish the political power of the hospital system. And they don't see this as significant, so I think we could probably get away with it while they weren't looking. Because they're, for them, primary care doesn't really matter.
Well, the question, you were talking about the superfluity of hospitals at Rhode Island. Could any of them be repurposed as community health centers so that people wouldn't be so worried about losing their jobs?
Actually, if we can talk specifically about the one in Kentucky, which I trained at and know pretty well, the building is kind of too big to do that with as a building, but boy, if you gave me enough money, I'd go around and build neighborhood health stations in 5 Pawtucket communities and employ almost as many people as we employed at Memorial, only we'd have way better health outcomes and way better service. And way less cost, way less cost.
You had a question?
Yeah, I'm curious as to your view of whether, now, in principle, the trick is how to get there. In principle, if you could make the branches of government do what they have to do and essentially put the kind of regulation on the more or less existing privately run health care system that we have now, do you think that is a way to get from A to B, or do you think you really are looking at this ground up, city by city, community process, and it's really a dichotomy where one is going to work and the other can't possibly work?
It's a great question, but I got to learn some things about the regulatory process at the Department of Health. There is a theoretical possibility to do it that way, but regulation requires political space, just like organizing requires political space. I learned very quickly and many times over that when we introduced a regulation that was politically difficult, that regulation would get shot down. And so I began to understand that I had to play an inside and outside game and work with people to develop the political space into which we could then move the regulatory apparatus. So once you've got to do the political organizing, you know, trying to deal with a legacy delivery system or delivery market, to me, you might as well just go ahead and use that political energy to organize in each community, and then you get both the political space and you get the delivery system that you need. But you know, the other thing is I've noticed over and over again that we really have most of the services we need. We don't have to like go around and build new hospitals or train new specialists. We actually have everybody in place. Most of what we have to do is reorganize them. But in order to get that done, that's the process of developing the political space. You know, I come to this notion that we have to build a movement, you know, with great trepidation. I mean, a movement is a big thing and will take forever to do. You know, I'm going to be long gone by the time this happens. On the other hand, I can't think of a meaningful alternative, an effective alternative.
I think this bottom-up approach is really inspirational in light of this behemoth that is overseeing the healthcare system. There are some countries that have managed to do complete overhauls in modern times. I want to say the Swiss, but it's rare. It's few and far between. But if you could close your eyes and implement something, is there a healthcare system of a different country that you would want to emulate?
Well, I think it actually makes sense to take a very close look at what they did in Finland. And I'm hearing, I haven't been there, but I'm actually hearing, you know, I know the Israeli one, which taught me a lot, and the one in Cuba. There's something different about medical education in Cuba. And we've just heard that Kaiser Permanente in California has decided to open its own medical school. And of all its own medical school, because they realized they needed more people to work in the primary care piece, and they weren't getting them from the medical education process that we have. And so where did they go when they wanted to look at a medical school? They actually went to Cuba. And I've actually, in a talk I gave about 3 weeks ago, I, for the first time in my life, met 3 of the 500 Americans who go to medical school in Cuba. There is something different about their education. They were the gentlest, kindest, and sweetest people. I can't begin to describe how different they were. And I was just overwhelmed by it. You can imagine us, thinking about that almost as foreign policy. And look at the difference between us and the Cubans in terms of how we deal with medical training. We drain the entire developing world of all their healthcare workers. The Cubans bring people from around the world, take them through medical school, and then send them home. Can you imagine a world in which, I was actually talking to somebody from Liberia today. I've been a little bit in Liberia and written a good bit about it. When I was there last, their medical school, they're a country of 4 million people. I got medical license number 66. And they were training in their medical school 13 people a year. Because of the difference in the cost of living, I think we once estimated that it would cost something like $80,000 a year to run a medical school for Liberia. imagine the world in which the United States went to the developing world and started running medical schools and training people to take care of communities. You know, that's us, that's this concept as foreign policy, but it's just as powerful as domestic policy, as we need it pretty desperately.
Hi, I'm very curious as to some of your thoughts on the government's role and the role of large hospital systems in addressing social determinants of health. We know that health is socio-ecological, right? 10 to 20%, depending on estimates that you look at, are medical, and the rest is genetic, hereditary, and then based on your social environment.
Education, housing,
Exactly.
community development.
Exactly, and we know that in our peer economically developed countries, that they spend, for every dollar they spend on, I think, socially, we spend about 52 cents last time I checked. So I'm curious as to just what you think of that, and if you think that that's something that we can change. And we see that they have better outcomes. Is that correlational or is that causation?
Well, let me see if I can go about this from a couple of different directions. The director of the Department of Public Health in LA, Mitch Katz, started building housing on the grounds of public hospitals in Los Angeles. He's now in New York, working for running Health and Hospitals Corporation. So I'm going to be interested to see what he does. That's on the one side. On the other side, I worry about asking healthcare people to take over social systems. And that's because we have medicalized almost everything. The cure for homelessness isn't medical care. The cure for homelessness is housing. And how have we allowed a world to exist in which we let the medical care market drain all the money we should be spending on housing? Instead, we should be using the democratic process to insist that we build the public housing we need and not have to take it through healthcare. What we call social determinants, I really worry that we are medicalizing all sorts of stuff. These are not really determinants so much as they are influencers. And I think our job is to recognize them and to bear witness and to challenge our colleagues elsewhere in the democracy to do their part to make sure these social problems get addressed with social problems, not more medical problems, not more medical processes.
Flint Water.
Flint Water is a great example. There was one doctor figured it out, and she stood up, but I was just at the APHA, the American Public Health Association, and talked to colleagues from Flint. And what's really interesting is even all this time, they don't have what they need to get a system of public health and primary care together moving. And that's a political problem.
How does insurance come into play in the community health centers?
Well, community health centers have a complicated financing mechanism. They get 10 to 20% of their budget, and Andrew, tell me if I'm wrong. Andrew Saul is the medical director, or the chief medical officer of Providence Community Health Centers. But 10 to 20% of their funding comes from the federal government in terms of grants, which they have to work endlessly hard to get. And then the rest of their funding is raised by traditional patient care, so they're better paid under Medicaid than others, and that helps them get that done. So insurance has a tiny role because most community health centers, while they take private insurance, it's not the dominant player in the people they take care of. And one thing you should know about community health centers, and again, I'm not sure I have the numbers perfect, but I can't remember if now we have 7 or 9 community health centers in Rhode Island. 9.
And 20% of the state gets primary care in the community health centers.
Right. So I thought it was 15, but 9 at 30 plus different sites, taking care of 150 to 200,000 people, and almost nobody who doesn't work in one knows they're there. In the United States as a whole, There are 1,400 at 9,000 different sites. They take care of 26 million people. And if we can do it for 26 million, why the heck can't we do it for 330 million and provide primary care to everybody?